this is a very big problem in Indian population because we are getting the diabetes in pregnancy is so common. Every third or the fourth pregnancy nowadays is associated with either pre-gestational diabetes or the gestational diabetes. It's a common medical complication of the pregnancy. Here you are treating the two generations, both the mother and the baby. So there is an increased risk of the maternal and the perinatal morbidity and the mortality. The complications, 1 and 20% of all pregnancies worldwide. Diabetes complicating pregnancy is more common in India because early onset of the type 2 diabetes. So we are getting the diabetes, type 2 diabetes at the age of 16 years, 17 years, 18 years. So probably by the time they got married and conceived, already with a 3 years history of diabetes, 4 years history of the type 2 diabetes is there. So that is the reason nowadays we are seeing a lot of the diabetes complicating pregnancies because of the early onset of the type 2 diabetes. So whenever you see a diabetes in pregnancy, you divide into two groups. One is first half of the pregnancy and the second one is in the second half of the pregnancy. In the first half of the pregnancy, we consider as the pre-gestational diabetes. So that is diabetes complicating the pregnancy, either the type 1 diabetic or the type 2 diabetes. So mostly the type 1 diabetes occurs less than the 20 years of age group. So at the age of 8 years, 9 years, 12 years, 13 years. So presented with your classical 3Ps, unintentional weight loss, sometimes maybe with the diabetic ketoacidosis as the initial presentation, and our diagnosis type 1 diabetes. That is easy at that time, but it is very, very difficult at the latter time because they have to keep on giving the basal bolus therapy, intensive insulin therapy, etc. And then the studies. So they have to study your intermediate or then your degrees or your professional degrees, etc. And the latter settlement in the jobs, and then finally the marriage and then the pregnancy. So by the time they are pregnant, they are already about 8 years or 10 years or 12 years history of type 1 diabetes. So the same thing now happening to the type 2 diabetes also. Okay, so you have to respect the diabetes management very much. So the pre-pregnancy counseling is also very, very important. Provided if the people are on the OHS in the type 2 diabetes at the age of 20 or 22 or 23 years, so definitely have to stop some drugs in the pre-pregnancy counseling. So the metformin is good, but all other drugs are not good during the pregnancy. So except the glibenclamide and the metformin, all other OHS have to be stopped and proceed to your insulin, and HbA1c should be around 6 and 6.5 before they conceive. Then only they will have a normal process of the pregnancy without any congenital malformations or without any maternal or neonatal mortality or the complications. So very, very important points here. Unfortunately, nowadays we are seeing a lot of pre-gestational diabetes also. And the second half of the pregnancy, the gestational diabetes. So they are lucky people because in the second half of the pregnancy, all organogenesis have done. No more any congenital malformations. Hardly they may develop the large baby, or sometimes maybe the cesarean section is needed, and there won't be any much very high maternal or neonatal mortality with the pure gestational diabetes because there are hardly 2 or 3 months with the hyperglycemia in the mother. But in the pre-gestational diabetes, so definitely all the 9 months they will be the hyperglycemic, they are the diabetics, very, very difficult to control because on one hand you are injecting the insulin, on the other hand lot of the hormones produced by the placenta. So that mismatch is always there. They are all counter-regulatory hormones. Even though you give 20 units, 30 units, 50 units a day, so definitely tomorrow or day after tomorrow again the fasting will be 130, 140, the postponed blood sugar will be 180, 190, 200. The targets are very, very low in pregnancy. What is the target fasting blood sugar in pregnancy? 90. What is the target blood sugar in postprandial in pregnancy? 120. So it is very difficult to reach that 90 and 120 with a minimal amount of the insulin in pre-gestational diabetes or pregnancy complicating diabetes complicating pregnancies. What are the effects of the pregnancy on the blood glucose? So pregnancy itself is a diabetogenic event. The woman is transformed from a physiological point of view by nutritional demands by the fetus. So you have to give high and high calories there. On the other hand, if you give the simple carbohydrates, the blood sugars will go up. And metabolic changes in the mother. So the fuel metabolism in the pregnancy, the insulin resistance increasing because of your counter-regulatory hormones, your placental hormones, because of the increase in the body weight. So during the pregnancy, every mother will gain nearly 8 to 12 kgs weight gain. That is the usual weight gain which occurs in the pregnancy is 8 to 12 kgs. So that itself will cause more and more insulin resistance. And there will be increased fat catabolism for the energy and reduces the muscle mass. And there will be the reduced energy to meet the maternal and the fetal needs. There will be the accelerated starvation. So because of these increased demands. So in a normal pregnancy, there are the increased insulin resistance, hyperinsulinemia, and changes in the fasting plasma glucose. Increased insulin resistance due to the increase in maternal hormones. HPL is the very, very important human placental lactogen, your progesterone, your estrogen, prolactin, cortisol. So these are all at higher levels. And as the pregnancy progresses, these hormones also will increase in its quantity and the quality production till the pregnancy reaches at the stage of 38th or the 40th week. Hyperinsulinemia, once there is an insulin resistance, so obviously your pancreas will secrete more and more insulin to compensate that insulin resistance. So hyperinsulinemia will always be there. And changes in the fasting plasma glucose. Due to the increased glucose clearance, increased fasting insulin, and the decreased hepatic output of the glucose, fasting glucose levels may be lower in the pregnancy compared to the non-gravid state. That is a very important practical point. In most of these mothers, diabetics, the fasting blood sugars will be at a lower level because the fetus has to spend 12 hours totally on the maternal feed. So that is the reason the fasting blood sugars will be at a lower level, and because of the other reasons also. See, on one hand, you have the anabolism, top of it, and the below you will have the catabolism. So this is anabolism because of your insulin resistance, hyperinsulinemia, hyperglycemia, and catabolism because of your lipolysis, ketogenesis, and hypoglycemia. See, anabolism during the feeding and catabolism during the fasting, they are exaggerated in a progressive fashion, reflecting the combined effects of the placental hormones. So as the gestational period increases, so all these counter-regulatory hormones will release. They cause more and more catabolism. So what are the effects of the diabetes on pregnancy? So maternal fetal nutrient transport. You see the bridge between the fetus and the mother is the placenta, and the glucose traverses through the placenta and reaches to the fetus. Amino acids travels from the mother, reaches the fetus through the placenta. Ketone bodies also goes there, but fats, triglycerides, no. Insulin, big no. Glucagon, no. So that is the reason we don't give the OHS. All the OHS will cross the placenta, whereas the insulin won't cross. That is the reason in pregnancy we use the insulin only to control the hyperglycemias. So the glucose, amino acids, ketones, they are all crosses, concentration dependent mechanism. Elevated maternal concentrations cause increased flux to the fetus. So for example, the mother's glucose is 200. So naturally it crosses to the placenta and reaches to the fetus, and fetus also will have hyperglycemia. Once the mother is having hyperglycemia, fetus will have hyperglycemia. And what about the fetal pancreas? So fetal pancreas, because of the more and more blood sugar in the fetus, that fetal pancreas itself causing more and more insulin. So there will be the hyperinsulinemia starts even in the intrauterine life. The fetal, that is the reason the fetus born to the diabetic mother, the baby born to the diabetic mother is also at risk of type 2 diabetes at a later time, because hyperinsulinemia will start from the birth. The stimulation of the fetal growth by the maternal diabetes. So the mother, placenta, so there will be the facilitated diffusion of the mixed nutrients. So again, these in the fetus, so they increase the insulin secretion. So because of the insulin is an anabolic hormone, once the fetus is secreting more and more insulin, hyperinsulinemia, the growth will. So that is the main large babies, 3.5 kgs, 4 kgs, just because of this growth because of the hyperinsulinemia, and that is the reason for your macrosomia in the fetus. So the maternal insulin deficiency leads to the increased catabolism, increase the nutrient flux across the placenta, stimulating the secretion of the insulin by the fetal pancreas, leading to the macrosomia. And this hypothesis is called Feddersen-Frenkel hypothesis. What are the effects of the fetal hyperinsulinemia? So there will be the growth of insulin sensitive tissues, increase the deposition of the adipose tissue, accelerated skeletal maturation, increased hepatic glycogen content, delayed pulmonary maturation. So that causes the impaired surfactant production. Delay in switch from the fetal hemoglobin to the adult hemoglobin, and polycythemia because of the increased erythropoietin production. So these are all the changes that occur because of the fetal hyperinsulinemia. Potentially teratogenic processes in the diabetic pregnancies. There will be the increased production of the oxygen-derived free radicals. They are not good for health. Abnormalities of the myoinositol and arachidonic acid metabolism. Abnormalities of the basement membrane components. Abnormalities of the zinc metabolism. So as a postgraduate, you should think of these things. Okay. So the lot of the changes are there because of the hyperglycemia. So that will lead to lot of defects in the fetus. What are the impact of the maternal diabetes on the fetal development? So stillbirth, due to the poor maternal metabolic control, the sugars are 250, 300 in the mother, so there will be the stillbirth. Neonatal hypoglycemia, due to the increased fetal insulin secretion in the response to the maternal hyperglycemia. Once immediately after the delivery, so when there is no maternal hyperglycemia to the fetal pancreas is secreting more and more insulin, there will be hyperinsulinemia. So that insulinemia will cause fetal hypoglycemia. So that is the reason neonatal hypoglycemia is a very, very common. The blood sugar will be 10, 20, 30, etc. And immediately the intensivist or the neonatologist will give dextrose to the newborn. Excessive growth and the fetal macrosomia, main reasons for your C-section in the diabetic individuals. See, the fetal macrosomia is the overabundance of the maternal nutrients, infantile hyperinsulinemia. Maternal diabetes induce anatomic and functional changes, altered maternal fetal nutrient transport, some genetic factors. So the maternal diabetes may induce susceptibility to the excess growth. These are the different malformations in infants of the mothers and the diabetes. So thanks to your TEFA scans, so most of these congenital malformations can be detected, and then they will be going for the termination of the pregnancy. So nowadays we are rarely see the people, newborns with these congenital malformations. See the caudal regression, spina bifida, timing of the lesion, weeks post-conception, 3 weeks, 6 weeks. Neural anomalies, anencephaly, myelocephaly, and hydrocephalus. So 4, 4, and 5th weeks. And cardiovascular, dextrocardia, conus arteriosus defects, VSDs, and the renal agenesis, renal hypoplasia. So these are the different malformations often see, and very, very costly malformations. Caudal regression syndrome, also called as the sacral agenesis, it is the most specific anomaly found in infants of the mothers with the diabetes, but that is rare. If you see the sacral agenesis, so definitely it's a case of the diabetes because it's a specific complication, but not a common complication. So what is most common is the neural tubal defects. But neural tubal defect is not a specific in diabetes. Neural tubal defects can be seen in other diseases also, but this is very common in the diabetes individuals. See the neonate here. So hypoglycemia, respiratory distress syndrome, hyperbilirubinemia, hypocalcemia, polycythemia, some traumatic injury if they attempted for the vaginal deliveries, hyaline membrane disease, and apnea and bradycardia. So the neonatologist has to be very much familiar and address, he has to address all these things. What about the long-term impact on the offspring? So they cause metabolic syndrome, obesity, hyperinsulinemia. So this hyperinsulinemia starts from his intrauterine life, and probably when they are 12 years, 15 years, 30 years, when they are obese, so obviously this hyperinsulinemia will not tackle the insulin resistance and then gives a way to the insulin resistance, and finally they will end up with early diabetes. So early onset of the type 2 diabetes is very common in these offsprings born to the diabetic mothers. What are the complications of the diabetes? Among the diabetes complicating pregnancy, one is toxemia, it is an emergency, acidosis because of uncontrolled diabetes, etc., and maybe the diabetic comas, maybe vascular complications, and very important in Indian population is the infections, maybe vaginal infections, maybe urinary infections, skin and subcutaneous, abdominal, respiratory. So all the infections are very, very common in these conditions. Other than them, the pregnant woman with the diabetes will have polyhydramnias, preeclampsia, preterm labor, postpartum bleeding, spontaneous abortion, and increased in C-sections. What are the maternal diabetes complications? Retinopathy can transiently worsen during the pregnancy. So that is the reason the pre-pregnancy counseling with the type 1 diabetes or early onset of type 2 diabetes wants to conceive pregnancy, you have to send to the ophthalmologist to rule out the proliferative diabetic retinopathy. So proliferative diabetic retinopathy is a contraindication for your pregnancy, because during the pregnancy the retinal detachment and sudden loss of the vision is very much possible. So first they have to go for the laser therapy and then treat the proliferative diabetic retinopathy very aggressively, then only say green signal to the pregnancy. In the same way, kidney function. So the proteinuria, 24 hours urine protein, urinary albumin creatinine ratio, and your creatinine levels, urea, your electrolytes. So these are the very important in the pre-pregnancy counseling. When they are elevated, so definitely you have to control them before give a green signal for the pregnancy. So don't use ACE inhibitors or ARBs. Again, in the pre-pregnancy counseling, once the fellow is on ACE or ARBs, they have to be stopped at least 1 month to 2 months prior to the pregnancy. So the kidney function can deteriorate in women with the CKD. Macrovascular complications like hypertension, ischemic heart disease, peripheral vascular disease are uncommon, as these women are usually the young. But Indian population, we are seeing ischemic heart disease even at the age of 18 years, 22 years, 23 years, before they marry, before they conceive. So some of the people are having vascular diseases. Increased risk of the death in patients with diabetic cardiomyopathy. So that's a muscle defect. So cardiomyopathies leading to a rejection fraction less than 40%, maybe 25, 30, 35. So they may not cope up with the workload of your pregnancy. So definitely with the lower EF, so definitely they are contraindicated for pregnancy. Autonomic neuropathy, so they lead to the anesthetic complications during the operative delivery. So these are the different complications. Unfortunately, we are seeing more and more complications nowadays because of the early onset with the diabetes and because of the late marriages. So we are getting the diabetes less than 20s and we are seeing the marriages after the 30s. So definitely there is a 10 to 15 years diabetic life is there before they conceive. So that is the main reason for the lot of the complications we are seeing nowadays. So coming to the gestational diabetes, is pure. So what you mean by the GDM? The definition is, it's a carbohydrate intolerance of variable severity with onset at the first recognition during the pregnancy. Okay, before the pregnancy, almost of the normal, they are euglycemic. Not a pre-diabetic, they are totally euglycemic. But after the pregnancy, so their sugars are going up. So this is a gestational diabetes. So before the pregnancy, if they are hyperglycemic, it is not a true gestational diabetes, but it is pre-gestational. or diabetes complicating pregnancy. The prevalence of GDM varies according to the population study, time of the testing, and the criteria used. Worldwide, the prevalence range from 1 to 15% of all pregnancies. The prevalence of GDM in a population is proportional to that of the type 2 diabetes and IGT in that population. So definitely we are having now the diabetic capital of the world, India. So the prevalence of the type 2 diabetes is about 11.5% and the prevalence of IGT is about 15%. So now we are having nearly 30 crores IGTs and about 13 crores type 2 diabetes. So India, the prevalence of the GDM, just 2% in 82. Now it is 16% in 2002. Now it has gone up to 29 to 30%. Amazing. So maybe after 20 years or 30 years, every pregnancy is a gestational pregnancy, either pre-gestational or gestational. So that's so common. See, 2% in 82, but now it is 16% in 2002. Now it is about 29 or 30% in 2025. So very high incidence of the GDM. The GDM incidence is increasing like anything, just like your type 2 diabetes. In a multi-center study in India, the lowest prevalence was found in Kashmir and the highest in the Tamil Nadu. Kashmir means a lot of Muslims. So they get married at the age of 14 years or 15 years. So already 4 or 5 children before 25, 26, and then termination of the pregnancy. But in Tamil Nadu and Andhra Pradesh and Telangana, so the people are getting married late 20s and early 30s. So that is the reason for this increased prevalence of the GDMs here. What is the pathophysiology? Women with a GDM are unable to increase their insulin levels sufficiently to overcome the insulin resistance produced by the pregnancy. So produced by the pregnancy and your hormones, your placental, human placental, lactogen, your progesterone, estrogen, etc. So the insulin resistance is the most important here. Insulin resistance usually increases in the second trimester as the placental hormogenesis increases. GDM is therefore seen in the 24th to 28th week of the gestation in most cases. So there is a bookish definition, 24 to 28 weeks. But nowadays we are seeing the GDM at 20th week, 21st week, at 19th week also. If you take a proper history, they are not a diabetics. No family history of the diabetes also. Earlier values, absolutely normal. But now they are the diabetics at the 20th week or 21st week. But the book says 24 to 28th week is the GDM. But practically we are seeing at least 3 to 4 weeks earlier to our bookish presentation. What are the implications? Women with the GDM, they are normoglycemic during the first trimester. It is the most important period of the organogenesis. If they are diabetic in the first trimester, that is the first 3 months, so the complications will be high, the congenital malformation will be very high. But fortunately in GDM, so they are not the diabetic in the first 3 months. So organogenesis are done. Their babies have a lower risk of developing the congenital anomalies than those of the women with the pre-existing diabetes. However, in the second half of the pregnancy, the risk of macrosomia, risk of stillbirth, prematurity, difficult labor because of the large babies, and neonatal metabolic complications like your hypoglycemia, hyperbilirubinemia, respiratory problems, hypocalcemia. So these are so common and comparable to the women with the diabetes complicating pregnancy. Infants of mothers with GDM are at high risk of developing the obesity, metabolic syndrome, type 2 diabetes, hypertension, cardiac problems later in the life. So they should maintain their ideal BMI. Their waist circumference should be always less than 90 in males and less than 80 in the females, and their BMI should be always less than 23. These populations, otherwise these are also going to have not only the diabetes and hypertension, metabolic syndrome. Women with GDM have high risk of developing the type 2 diabetes later in the life. So the most important advice for these mothers are get the blood sugar done after 6 weeks of postpartum period. But once after the delivery, the blood sugars are normal, so they forget. The obese specialist also, they may not request these fellows to come after 6 weeks of the pregnancy to go for the GTT or to get the blood sugars done. So everyone neglects it, and finally after 2 years or 3 years of the delivery, so they will come up to a physician with very high blood sugars. So very, very important take home point is we have to address the mothers for the follow up of the diabetes. Even though the blood sugars are the normal immediately after the delivery, because the placenta is out, the blood sugars are out. But they are at risk of getting the type 2 diabetes. So screening is very important. Follow up is very important. So the first follow up 6 weeks after the pregnancy, after the delivery. And the second one 6 months. And then third one every year. So every year they have to go for the fasting blood sugar, PP blood sugar to detect the diabetes at an early time. Otherwise, they will land up with very high blood sugars and also with some complications. That is what we are seeing nowadays. Whenever you see a female with a type 2 diabetes, if I ask a leading question, do you have a history of the GDM? Yes. In the first pregnancy, the second pregnancy, or in the third pregnancy, etc. So whatever their sugar testing after the delivery? No. They didn't tested the blood sugars after 6 weeks of the delivery or the 6 months of the delivery or the every year. So they land up with the fasting blood sugar 200, postpone blood sugar 300, then they end up with our for us, for the proper management of the diabetes. So had they tested for these blood sugars periodically, so definitely we can postpone the onset to the diabetes in here. The most important point is we should not get the diabetes at an younger age. We try to postpone the diabetes incidence or onset. So after the onset, all the complications will be associated with your duration of the diabetes and your onset of the diabetes. Suppose if you get the diabetes at 50 years of the age group, you may develop the complications at 65 or 70 years of the age group. On the other hand, if you get the diabetes at 25 years of the age group, so at the age of 35 or the 40, suppose if you are going to get the CKD or the IHD or etc., so then definitely your personal life is at trouble, your family life is at trouble, and also all the society also will lose very, very important outputs from this population. So our aim is avoid early onset of the diabetes, postpone the diabetes, identify the pre-diabetes, and give good dietary approach and good exercise, etc., so that they will live with euglycemia for at least another 5 years or the 10 years. So that makes a lot of the difference in causation of the complications at a later time. So what about the universal and the selective screening? American Diabetic Association recommends the selective screening. No need to screen low risk group. Who are at low risk group? Age less than 25 years, weight normal before the pregnancy, member of an ethnic group with low prevalence of the GDM, no known diabetes in the first degree relatives, no history of abnormal glucose tolerance, no history of poor obstetric outcome. But all are yes, yes, yes for Indians. So for us, age more than 25 years is so common nowadays. Weight normal before the pregnancy. So before the pregnancy, most of the women are overweight and some are obese also. And then member of an ethnic group with low prevalence of GDM. Indian itself is a high ethnicity group. Asians and Indians, high ethnicity group. Even though you don't have any family history of the diabetes, still you are at risk of getting the diabetes just because you are an Indian. No known diabetes in the first degree relatives. So the diabetes runs in our families. Maybe your aunt, maybe your uncle, maybe your grandmother or grandfather, etc., etc., your sisters, your mother, or father. So definitely there is a history of the diabetes in us families. So these are the reasons. So selective screening is not good for Indian population. We need universal screening. All the pregnant women should be screened for diabetes. Indian scenario, Indians are at high risk group. So hence all pregnant Indian women should be screened for the diabetes. At which visit? At the first visit itself. So all pregnant Indian women should be screened for the diabetes. Screen for undiagnosed sensor. Screen for undiagnosed type 2 diabetes at the first prenatal visit. Using the standard diagnostic tools and criteria. Fasting, HbA1c, or 2 hours postprandial, following a 75 grams glucose. It depends on the input you are getting it. Suppose you are giving the 100 grams glucose, then you will get the 3 or the 4 values. So fasting, first hour, second hour, third hour. If you are giving the 75 grams OGTT, maybe 3 values. So fasting, first hour and the second hour. And the values also will change. 93, 160, 180, 140, etc. In women who screen negative at the first visit, so don't think that they won't get any diabetes at the later time. Again, perform a 75 grams OGTT at 24 to 28 weeks and interpret using the criteria recommended by International Association of Diabetes Pregnancy Study Group. So you need not bother about these things. The 2 points are very clear. On the day 1 of the antenatal visit, first antenatal visit, you screen for diabetes. If there are diabetics, so there must be a diabetes complicating pregnancy. Okay, so either the type 1 diabetes or type 2 diabetes, and they act accordingly. So they need insulin from the day 1. Suppose if they are not a diabetics in the first antenatal visit, but again tell them to get these tests done at 24 to 28 weeks to rule out second half of the pregnancy, that is GDM, true GDM. So by the time they know that pregnancy, they are already in the second or the third. What is the diagnosis of the diabetes here? GDM here, 75 grams. Fasting, more than 92. First hour, 180. Second hour, 153. Any one value is sufficient to consider them as the GDMs. This is the very important. So some people say 92, but you can remember as a 90. Okay. And instead of 153, you remember as 150. So 90, 180, 150. 0, first hour, second hour. Any one is abnormal, one value is abnormal, you can consider them as the GDM. Suppose fasting is 80, first hour is 200, second hour 140. They are GDMs. Fasting 95, first hour 150, second hour 100. Still GDM because first hour is 95. In the same way, first hour 80, second hour 100, first hour 100 and second hour 160. So they are the GDMs. Okay. Any one abnormal value is sufficient for the diagnosis of the GDM. There are concerns that use of these criteria may lead to our diagnosis of the GDM. However, they have been accepted by the ADA and the WHO. Because we are going to harm both the mother as well as the fetus. See here, a 28-year-old lady with a bad obstetric history, with a 6 months amenorrhea, has the following GTT using your 75 grams glucose. 86, 188, 146. So what is your diagnosis? What is the abnormal value here? 60 minutes, 1 hour. It should be less than 180. Here is 188. 0, it should be less than 90. Okay. Second hour, less than 150. Indian guidelines. This is the important guidelines. DIPSI. They recommend a one-step procedure using a 75 grams OGTT, 2-hour plasma glucose diagnostic criteria. More than 200 is a diabetes. 140 to 199 is IGT in the general population, but in pregnancy it is GDM. So in a single word, what is IGT in a non-diabetic, non-pregnant woman is GDM in pregnancy. Am I clear? More than 200, it is established diagnosis, established diabetes. Between 141 to 199, it is IGT in a non-pregnant woman. In a pregnant woman, it is GDM. So when to screen? As early as possible during the gestation, the first antenatal visit itself. If found negative, don't be happy. Then tell them, even though this is a negative, so screen again for between 24 to 28 weeks of gestation. So what about the management of the diabetes in pregnancy? See, the pre-pregnancy control and the counseling is very important. I told you something about your retina, something about your kidneys, and about your HbA1c and about your OHS, and control during the pregnancy. So entire the pregnancy period, you have to control these sugars very well, either with your metformin or with your insulin. Usually you don't use glibenclamide, whereas in African countries they use the glibenclamide as also during the pregnancy, but in India we use only metformin and insulin. And post-pregnancy control, so obviously the sugars will be 0 in most of the GDMs. Very few people, maybe 1 to 2% of the GDMs, they keep on hyperglycemic even after the delivery also. So they may require some metformin, etc. Not much insulin also. So that is the reason. Don't tell that after the delivery you are become the euglycemic 100%, even though it's a GDM. Okay, 99% they will be euglycemic after the delivery, but 1% they keep on living in that phase of hyperglycemia. So otherwise, you know what they do? 100% will be euglycemic after the delivery, and then neglecting their hyperglycemia, and after 6 months or 7 months, they will end up with DKA, because after the delivery also their blood sugars are 200, 220, because they thought that after the delivery my sugars will be the normal, I don't require any treatment. So they keep on doing like that for 2 months or 3 months, and finally their blood sugars will be 300, 400, 500, and land up with DKA. So that possibility is there. Some of my patients, you know, even after the delivery, even though that comes normal, some people are continuing the pregnancy, continuing the diabetes. So that option is also must be there. And of course, post-pregnancy control. Okay, so there should be a gap between the pregnancies, and again, good counseling you should give to cope up the health of the mother and also the child. Pre-pregnancy diabetes clinic, educate and obtain the maximum cooperation from both the partners. Obtain the optimum diabetic control before the conception. Your HbA1c less than 6%, not even the 6.5%. Before the pregnancy should be normal only. Normal means 5.7, less than 5.7. Identify the time of conception accurately. Check the immune status against the rubella. Encourage the good general principles of the health and the hygiene. So this is the pre-pregnancy counseling, understanding the risks of the perinatal mortality, congenital malformations, maternal mortality, diabetes complications in the pregnancy, obstetric complications, inheritance of the diabetes in the offspring. So runs in the generations, 2 generations. What a diabetic pregnancy involves: frequent antenatal visits. It is a very, very important. And then the close supervision, strict blood glucose control, appropriate diet rich with the proteins, diet rich with unsaturated, polyunsaturated, limited saturated fats, and very limited simple sugars. So these are the very important. It's a very, very important. Okay. Initial evaluation of the pregnant woman with the diabetes. Optimize the glycemic control. Self-monitoring and education is very important. Adjust the insulin regimen if necessary. Check the diet and check the HbA1c. Preconception targets. Preprandial blood glucose less than 90. Postprandial blood glucose less than 120. HbA1c in the non-diabetic range. Okay, it's not the 6.5, but it's 5.7. 5.7 to 6.4 is pre-diabetic, and more than 6.5 is the diabetic. So you have to aim for the normal range. So the fasting less than 90, postprandial less than 120, and HbA1c less than 5.7. Here another case, a female, 32-year-old, planning to conceive her second child. She is known to have the diabetes for the past 2 years. A typical GSL medical graduate, postgraduate. Okay. She is currently taking tab glimepiride 2 milligrams BD, metformin 5 milligrams BD. A1C 6.8. Is conception advisable at this level of the glycemic control? So age 32 years, diabetes 2 years. Okay. And this is her conceive her second child, planning to conceive her second child. So G2. So currently taking the glimepiride, sulfonylureas plus the metformin. So what is your advice to this? What are all the parameters you are supposed to see? So stress on weight reduction if they are overweight and obesity. Check the blood pressure. Okay. Again, very high blood sugar, very high blood pressures. You have to give the drugs. Which drugs you prescribe here? Suppose she is in hypertensive. The blood pressure is 160 by 100. So don't use ACE inhibitors or ARBs. Okay. Use beta blockers or calcium channel blockers. Don't give the diuretics also. So diuretics and ACE and ARBs are contraindicated. Okay, fine. So whatever the diabetes. Now the HbA1c is 6.8. Are you happy? 6.8? No. She want to conceive her second child. So HbA1c should be. Now this is going to be diabetes complicating pregnancy, not the GDM. Diabetes complicating pregnancy. So the congenital malformation is very high. Your organogenesis will occur in the first 3 months. So definitely you have to address HbA1c. So HbA1c around 5.7. So what to do with your medication? Good, right answer. Right answer. Once the HbA1c is beyond 6.5 before conception, so change to insulin. So is conception advisable at this level of the glycemic control? No. So for the conception, the HbA1c should be less than 5.7 and the glimepiride has to be stopped. And metformin also has to be stopped because it's a diabetes complicating pregnancy. Insulin is the drug of the choice. We don't use the metformin on the first month and the second month, the third month of the pregnancies. Usually we use in the true gestational diabetes. What advice will you give her regarding the OHS? So stop OHS, start insulin. So the diet is very important. Blood glucose determination is also very important, SMBG. So all our GDM people know. Usually we give one glucometer and we have to maintain their logbook. So one day fasting blood sugar, second day pre-lunch, third day pre-dinner, and then fourth day at the time of the bedtime. So that's how they have to get the blood sugars done till your next visit. And then you have to see this logbook and at what time the blood sugars are very high and adjust the doses of the insulin accordingly. And exercise is very important. Even in the 8th month and the 9th month, upper body exercises. So exercise only will reduce your insulin resistance. So diabetes itself is a diabetogenic state, insulin resistance because of the hormones. So once the exercise is there, at least the upper body exercises, the blood glucose will go to the muscles and the adipose tissue and insulin sensitivity will be increased and intense insulin regimen. So I have to give 3 shots or 4 shots are very much needed in order to keep the fasting blood sugar less than 90, postprandial blood sugar less than 120. It is very easy to say, but very, very difficult in diabetes complicating pregnancy, that is pre-gestational diabetes. So the planned physical activity 30 to 45 minutes a day is recommended. Complements the dietary recommendations. The activities that increase the blood pressure should be avoided. Upper body exercises are very much recommended. If physical activity is restricted by the obstetrician, then the patient should adhere to this advice. Daily nutritional requirements for patients with the diabetes during the pregnancy. The calories, carbohydrates, the protein, the fat, iron, folic acid, calcium, vitamin B12. So these are very much needed for all the diabetic individuals. Indian Madam Rajkumar garu. Okay. You want to listen? Okay, sit down. Okay, fine. So SMBG should be performed several times a day. Urine glucose monitoring may be unreliable. So don't test the urine glucose, urine sugar, even in the diabetic or non-diabetic. Even the most of the times in pregnancy, no. Even though the blood sugars are normal, urine sugar may be positive. Urine ketone monitoring is very, very important, especially in the type 1 diabetes turning to the pregnancy or the type 2 diabetes turning to the pregnancy. If women treated with the calorie restriction, so there will be the fasting period, there will be the more and more ketone bodies positivity. HbA1 can serve as an indicator of the glycemic control, especially in the type 1 diabetes or pregnancy or diabetes complicating pregnancy. Whereas in the GDM, I don't think that HbA1 will help you. because a true GDM is hardly a period of about 1.5 months or 2 months or 3 months. So their fructosamine rather than the HbA1c is the marker in pregnancy. Till 28th week, lab monitoring of the plasma glucose can be done once a month. That depends on the individual. Sometimes we say once a month or 15 days or 10 days or every week, etc. From 28th to 32nd week, once in 2 weeks. From 32nd week onwards, once in a week. Monitoring should be performed more frequently for the high-risk pregnancies. So nowadays, we are seeing more of high-risk pregnancies. So good monitoring and close monitoring is very important. Fetal abdominal circumference as a marker of the abdominal metabolic control. Now our radiology friends know, they give us the fetal abdominal circumference. Fetal abdominal circumference, AC, and the Likert volume by the ultrasound, starting in the second or early third trimesters and repeated every 4 weeks, can help guide the management decisions. The fetus of the diabetic mothers, there is disproportionate increase of the fetal abdominal circumference compared to the other ultrasound biometric parameters of the fetus like BPD, HC, and FL. So that is your femur length, your head circumference, or biparietal diameter. So they also give these markers. They do it. So this is the biometric scans. Now the obstetric management. This is the very important. So first trimester, what to do? Menstrual history and the date of the last menstrual period has to be calculated. Blood pressure recording is very important. Weight measurement and provision of appropriate dietary advice. Optimize the glycemic control. So teach home glucose monitoring and insulin therapy is very important. HbA1c is important. Renal function tests, especially the creatinine calculation, GFR, and albuminuria or UACR. Baseline ophthalmic examination or fundus examination. Counseling for risk of the congenital anomalies because it occurs in the first trimester. Ultrasound for fetal viability and the dating and anomalies. So these are very important decisions or inputs you have to give to the mother in the first trimester. What about the second trimester? Again, the blood pressure measuring, weight, and small talk on the diet, and monitor the glycemic control. See the logbook, the renal functions. Again, the fundus examination, ultrasound for major anomalies, and check for the complications like pre-eclampsia, polyhydramnios, etc. This is the very important. Again, the third trimester, blood pressure and weight and diet, glycemic control, renal function test, frequent ultrasound for macrosomia and the Likert volume. Check for the maternal complications like pre-eclampsia and preterm labor. Now the obstetrics. While planning the timing of the delivery, the obstetrician has to balance the risk associated with the prematurity and those associated with the waiting too long. So this is the decision they have to take it. So when to plan for the delivery. Most OBG, they allow the diet treated GDM to continue till the 40 weeks. So nothing will happen. But insulin treated patients are usually not allowed to go beyond 38 completed weeks. Mode of the delivery is dictated by the obstetric considerations. Diabetes per se is not an indication for the cesarean section. Okay. When early delivery is contemplated, the risk of iatrogenic prematurity and respiratory distress syndrome should be kept in the mind. Antenatal use of the systemic steroids to accelerate the fetal lung maturation is not contraindicated in a mother with a diabetes, even though the patient takes the, we should not say the patient, even though the lady takes the insulin, you have to increase the dose of the insulin according to your steroid therapy. Insulin doses will have to be titrated upwards. So once you are giving the steroid, the sugars will go up. So you have to adjust the doses of the insulin accordingly. But steroid has to be given to improve the lung function. Management of the diabetes in pregnancy. Do not attempt weight reduction during the pregnancy. That is very important. Okay. because they have to gain weight of nearly 8 to 10 kgs or 12 kgs during the pregnancy. However, avoid the excess weight gain, not 12 kgs, more than the 12 kgs or more than 10 kgs during the pregnancy. For obese women, diet with 30 to 33% calories restriction, about 25 calories per kg body weight, preconceptional supplementation of the folic acid. Exercise, already I told you. Management of the diabetes in pregnancy, insulin requirements. When is insulin needed? See, very simple. When is insulin needed? When the fasting more than 90, 2 hours more than 120, you need insulin. So simple in pregnancy and diabetes. Your targets are 90 and 20. When the sugars are more than that, you need insulin. So the gestational, pre-existing. See the gestational diabetes. Women with GDM usually have elevation of the postprandial glucose, not the fasting. In the true GDM, they have the postprandial hyperglycemia. So usually with your regular insulin or with the rapid acting insulin, you can control. So they require 1 or 2 more doses of the prandial insulin along with the meals that are also the greatest glucose excursions. So you require the regular insulin or long short acting insulins just before the breakfast and lunch. Usually you don't give before the dinner. So before dinner you give the regular insulin. So the persons may get hypoglycemia at the midnight. And the baby, the fetus has to depend on the mother's blood glucose only during the entire night period. Night they don't take anything. So they are on the fasting in the night. So that is the reason usually you give before breakfast and the before lunch. We don't give the insulin before the dinner in true gestational diabetes individuals. If the fasting blood sugar is high, a night dose may have to be added. Very, very rarely. When the fasting is 140, 130, 180, oh, that is very high. So definitely they need a dose at the night time. But otherwise, usually the fasting blood sugar will be at a lower level, but the postprandial blood sugar will be higher level. In pre-existing type 1 diabetes, already type 1, so definitely, as Nijasri is saying that, basal bolus therapy. Because of the type 1 diabetes, entering into the pregnancy, they need 4 shots a day. See the multiple injections, regular, lunch, either regular or rapid. So regular your Actrapid, rapid is your Lispro or Glulicin, etc. Lunch, same thing. Bedtime, intermediate or the long acting is the basal insulin, like your Glargine or your Deglutec, etc. Intermediate is Insulatard. Targets in the pregnancy, 90 and 120. Insulin management during the delivery and the labor. Usual dose of intermediate acting insulin is given at the bedtime. Morning dose of the insulin is withheld during the labor. Usually they are posted for the CS mornings. IV infusion of the normal saline is begun. Don't give the RL. Once active labor begins or the glucose levels fall to less than 70, the infusion is changed from saline to the 5% dextrose and delivered at a rate of 2.5 milligrams per kg per minute. That depends on your maybe 60 ml per hour or 100 ml per hour or 150 ml per hour. Accordingly, you can advise them. Glucose levels are checked hourly using a glucose meter, allowing for the adjustments in the infusion rate. Regular insulin is administered by IV infusion if the glucose levels are beyond 140. So during the labor, the levels are somewhere between 140 to 180. So the labor, diabetes complications, retinopathy, nephropathy. So key to successful management of the diabetes, completing pregnancy. Focus on preconception counseling. That is a very important. Provided if the persons are type 1 diabetes and early onset type 2 diabetes. Contraception until tight blood glucose is achieved. So this is very, very important. Tight blood glucose to be maintained throughout the pregnancy. Throughout the pregnancy, the fasting should be less than 90 and postpartum should be less than 120. Timing of the delivery to be carefully planned. Meticulous follow-up after the delivery is essential. After the delivery also, the follow-up is very important. Vigilant surveillance and management of the diabetes complications. Close partnership between the diabetologist and OBG. It is very much essential. So prevention of the diabetes, postpartum follow-up GTT is mandatory in all cases of the GDM 6 weeks after the delivery. Normal glucose tolerance, reassessment of the glycemia at 3-year intervals, pre-diabetes, diabetes and all GDMs, lifestyle modifications. Postpartum management plan. The plan should be individualized, glycemic management, nutrition management, contraception prescription, future pregnancy planning, lifestyle changes. Follow up the OGTT 6 weeks postpartum is a must in all cases of the GDM. Importance of the weight management. Weight loss reduces the risk of the developing the GDM in the subsequent pregnancy. Whatever the weight gained during the pregnancy, I am saying that 8 to 12 kgs, they have to lose the weight after the delivery. Otherwise, if they keep on continuing the same weight, so definitely they will going to get the type 2 diabetes much early. So the weight loss after the delivery is very much important. The risk of the type 2 diabetes increases by 18% per unit of BMI. If you are above the BMI, your targets, so the more rapidly you are reaching the stage of the diabetes. Post-delivery lifestyle interventions are effective in reducing the risks. Follow-up, good control of diabetes during pregnancy can improve the intrauterine environment, reduce the risk of the macrosomia, and minimize the future risk of diabetes in the offspring. Lifestyle modifications can delay or prevent onset of the type 2 diabetes in their lifetime. So that finishes our pregnancy in diabetes. Okay, thank you. Attendance?